So I didn't say I'm checking his posture, right? I'm just going to touch a couple landmarks so he doesn't change anything. I'll just go down, paint the fence, checking the spine. Someone asked what I was checking for yesterday. I'm just looking for any abnormal curvature, scoliosis and things, right? Or maybe even something more subtle if you get to that level of palpation. I use the back of my hands. I just didn't realize I even do that until having to describe it yesterday. But I'm just touching his back to feel his muscle tone at the same time. And then I reach around, down, up, down for the iliac crest. I'm looking for the level. Looks fine. Can you stand with your feet together, please? I'll just check that again. And what you could also do is you can come down and feel the greater trochanterus. I usually would do that as well, since I'm here. And then you can look at the back of the knees real quick, and you can look to see his left foot's pronated, his right foot's supinated, which is what I'm doing right now. And then I'm going to have you go through some motions if that's okay. I don't want you to hurt yourself. Just do what's in your comfort level, okay? With your knees totally straight, I'm going to have you bend forward as far as you can. So I'm looking for the curvature. I'm looking for it to be shifted posteriorly. And you come back up. You do that one more time, please. Good. And then you come back up. Now, he's very limber. Just so you guys know, some patients can hide findings when they're very limber. So one thing you'll notice, like let's say I have him do it again. Let's say he came in with lumbar radiculopathy. And I'm like, wow, you have really great range of motion. But just always pay attention because there's something I did observe that we can still check. Can you bend forward one more time? And if you look, his head is extended. Can you relax your neck? There you go. And then go ahead and come back up. Now, if I had him relax his neck and he said his pain, he felt a little bit of pain with that, what would you start thinking? Neural tension. That's all I would think. Doesn't tell me anything else, but it tells me if he's not feeling anything with his head extended, that's a compensation. And then all of a sudden he relaxes his neck and, oh, no, I feel some discomfort in my leg. That would be a confirmative finding, but because he's so mobile, patients can hide that. Okay, so I'm going to have you go backwards. Okay, go back up. Any discomfort with that? So I usually ask them if they have any discomfort. I don't usually say, oh, is that hurting right here? Did you have pain right here when you did that? That's a leading question that I want to avoid. Any discomfort? Anything? Right? Okay, can you bend to the side, please? So here you can measure fingertips to the knee line distance, or you can measure from the floor to the fingertips. We'll go the other way. Same thing over here. You're looking for any rotations, any tilts, compensations. Looking for a nice C curve of his body. Come back up. I'm going to roll up your shirt if that's okay. I want to look at your spine. Take a bend over the left one more time. So here you can look and see the curvature of the spine, see if there's any points where it's hinging. Can you go the other way? All right, come back up. Bring that down. And then I'm just going to have you rotate, twist as far as you can to the left. Good. To the right. Good. Come back to center. Something I also do that I didn't really mention in the notes is I'll block his hips. Can you turn to the left one more time? And then to the right one more time. Good. Come back up. So sometimes I'll do that, sometimes I don't. It just depends on what I'm looking for. But what I did is try to take the lower part out of the equation, see if it's more, coming from the upper part.
One question.
Yeah.
This posture is very unstable. How the older people can...
Good question. If it's an older person, I'll have them separate their legs.
Okay.
And sometimes I won't even do this if they have balance issues. They might fall over. You gotta you gotta know the rules before you break them, right? But you have to also adapt to whatever you're dealing with. So if the patient's in a lot of pain, or if they're older, they're unstable, whatever's going on, you gotta adapt to that situation. And if you don't, then you're not really listening to the patient, right? So like I said, do not hurt yourself. If anything's uncomfortable, please stop. I don't want to irritate his symptoms so bad that he's walking out worse. I'm trying to get some information to treat him better. And it's only what the patient can give me in that moment. Yeah. All right. So your rotation. Can you just raise both arms overhead? Good. Come back down. Let's see, thumbs up, arms straight. So normally I'll cue them thumbs up, arms straight. Go over here. And I'll slide over to the front and just see that his right side is tighter, right? I'm looking for his palms. That has some indication for tightness in the internal rotators, right? Lats, teres major, pecs. Come back down. Good. Now we're gonna just do the left arm. You're gonna raise it straight up with your thumb up, just like that. Come back down. And this time you're gonna do it when I say go. Ready, set, go. Good. Come back down. Now you're gonna do the other side. Ready, set, go. Come back down. Can you karate chop your hands together like this? Arms totally straight. And then you just turn to the left as far as you can. Great. Go the other way. Okay. Go the other way one more time. Okay. Come back to center. Can you face this wall, please? Let's do it one more time. Go to the left. Go to the right. Okay, yeah, that's better. Okay. So go to the last. I had him do it again because he wasn't going as far one way, but he corrected it.
Quick one, Jamie, when you do that arm raise with your hand on the low back, what is that an indication possibly of?
Well, I'm just looking to see if the multifidi can initiate contraction right away.
Gotcha.
So if there is some atrophy there, the contraction will be delayed. That's what I'm looking for.
Okay, got it.
And atrophy is extremely common with any lumbar disc, facet type of thing, because they all share the same type of innervation. Right, so there's a lot of research that shows that the muscle becomes marbleized. It's infiltrated with fat, right? And a fatty muscle is not very useful. Okay, so that was the upper part. Can I, still facing me, can you separate your legs shoulder width apart? Let's have you cross your arms, and I just want to see how you do a squat. Good, come back up. Just do it one more time.
Just low.
Come back up. It's like perfect, right? Okay, thank you. And can you hold your hands like this? Actually, like face me, please. Hold your hands like this, bring your feet together. I'm just gonna have you lift one foot and just hold your balance. And if you lose your balance, you can grab me. Okay, go back down. Try the other side. This time I want you to keep your other leg totally straight.
Extended.
This is good. Go the other way, go. Keep that leg totally straight. Thank you, that's good. So, did you guys catch that? That was a good example. Very subtle though, right? Normally I just have them lift the foot. They can do Karate Kid too, it's okay. People do it that way as well. So what did you guys see when I had him do it on the right side? Right? Right after how many seconds? Like 1 or 2 seconds. He hides it though. And he also hit it. He's got a little bit of baggy pants. He bent his knee a little bit. What does that do? Allows you to get the glutes involved a little bit more, right? Get the glute max involved, right? That's like how you do a front kick type of feeling. But once he straightened it, that's, so you got to do everything really systematically. It's got to be correct or your results are not going to be the same. So really, the basics are the advanced techniques. You just got to know the basics really well. Because if you didn't look at his knee, you missed it. You know what I mean? Okay, where are we? Can you walk on your heels, please? Good. And can you come towards me and walk on your toes? Okay, can you face this way? Can you go up on your toes real slowly? Good. All right, good. You want to see the calcaneus invert. He does it really nicely. Come back down. And then he's very functional. Can you do 10 more of those? And then you get it.
Shoes off.
Just like that's fine. So normally in the clinic, yes, you do a shoes off. If you can. Some people don't want to take their shoes off though because they think your floor is dirty. So whatever, you know, just do what you got to do in the moment. You know, we're just trying to figure out where to put the needles.
Do you do all this for every patient, Jamie?
Yes, I do. And it's when I'm not talking, it's not that. It doesn't take that long.
Okay.
Yeah, and I think what my problem is you know, if I didn't know how to do this, you're like ignorance is bliss. But once you learn it, like I cannot do it because then I feel bad that I didn't give my best.
You're lost.
I felt like I just didn't give my best, and I can't live with that, you know? Yeah.